Hi there, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some precious tips which may prove useful in your line of duty. Welcome. So welcome to part 61 of our pharmacotherapy MCQ series, measuring in pulmonology. And question 1 reads, Mrs. T.O.O., a 27-year-old female with a known past medical history of asthma, for which she has on several occasions been previously admitted to your hospital, with the last admission requiring intubation, is rushed to hospital by ambulance with some shortness of breath worsening over the past 1 day, which has failed to respond to her use of salbutamol nebulization therapy, which she was using at home. She receives Dexamethasone 10 milligrams IV start, an initial dose of Ipratropium and salbutamol in the ambulance. So my question to you is, which of the statements below is true about this particular clinical case scenario? Is it A, the addition of Ipratropium for an asthma exacerbation isn't likely to provide any benefit like that seen in COPD? Or is it true that dexamethasone administered via intravenous infusion can cause bronchodilation within 15 minutes? Or is it true that ipratropium has a shorter duration of action than salbutamol? Or is it true that salbutamol has an earlier onset of action but shorter duration of action compared to ipratropium? I'll give you 10 seconds to choose the correct answer. So D is the correct answer. It's true that salbutamol has an earlier onset of action but a shorter duration of action compared to ipratropium. Now the onset of salbutamol action is within 15 minutes, and it peaks at around half an hour if I remember well, and it lasts over 2 to 6 hours, whereas ipratropium has an onset of within 30 minutes. It peaks at 1 to 2 hours and can last up to 4 to 5 hours, and there are exceptional cases where it may last up to 6 to 8 hours, creating an overlap with the bronchodilatory effect of the same. Now, due to the slight delays in the onset of action of both steroids and ipratropium, the salbutamol is likely to be the only treatment helping the patients early on in the acute management of asthma exacerbations. Now, this does not mean we still don't admit them early in order to get them to start taking effect as soon as possible. Now, just like to emphasize that dexamethasone is a corticosteroid and doesn't cause any bronchodilation directly on its own. And while ipratropium may be more commonly used in the chronic management of chronic obstructive pulmonary disease, it is helpful in the acute asthma exacerbation management as well. So we don't restrict it to the COPD patients alone. Let's move to the next question, please. And the next question reads, mepolizumab, marketed as Nucala, is a novel pharmacotherapy for the management of asthma in specific patient populations. My question to you is, which of the statements below best describes its impact on asthma pathophysiology? Is it true that it is a leukotriene inhibitor, or is it an interleukin-5 inhibitor, or is it a long-acting muscarinic agonist, or is it a tumor necrosis factor alpha inhibitor? I'll give you 10 seconds to choose the correct answer. B is the correct answer. It is an interleukin-5 inhibitor. Mepolizumab is an interleukin-5 antagonist which reduces the production and survival of eosinophils. Now, by reducing the function and the number of eosinophils, mepolizumab may prevent the release of pro-inflammatory mediators, may also limit the release of cytotoxic mediators and even cytokines that contribute to asthma or asthmatic attacks. I would like to add that leukotriene inhibitors such as montelukast inhibit 5-lipoxygenase activity. Now, since leukotriene or the leukotrienes are anti-inflammatory mediators which are released from eosinophils, if I remember well, such agents can help with eosinophilic asthma. I would also like to add that long-acting antimuscarinic agents, what we abbreviate as the LAMA, such as tiotropium, can be used in combination with inhaled corticosteroids for the treatment of asthma. However, there is insufficient evidence to recommend LAMA plus ICS over LABA, the long-acting beta agonist, plus ICS. There is lack of evidence in literature. Now, I would like to add that tumor necrosis factor alpha inhibitors such as infliximab, which is marketed as Remicade, or adalimumab, which is marketed as Humira, don't have a role in asthma therapy. I would like to remind you that infliximab and adalimumab are both known as monoclonal antibodies. If you look at their names, they end in MAB. Now, the interleukin pathways in asthma contribute to eosinophilic activation and inflammation. Now, interleukin inhibitors are useful tools in the treatment of stage 5 asthma, to be specific, and they serve usually as add-on therapies in the management of patients with stage 5 asthma. That's just a by the way. Let's move to the next question, please. And it reads, Prorenata or as needed inhaled corticosteroids are recommended as the preferred control agents for step 1 asthma by the Global Strategy for Asthma Management and Prevention. So my question to you is, which of the adverse drug reactions listed below, which are associated with the ICS therapy, can be lowered when spacer devices are used during the administration of these medications? Is it osteoporosis, dysphonia, hyperglycemia, or glaucoma? I'll give you 10 seconds to choose the correct answer. So dysphonia is the correct answer. I would like to emphasize that the use of a spacer device with an inhaled corticosteroid MDI, metered dose inhalers, can decrease the incidence and severity of local side effects, which include dysphonia, and oropharyngeal candidiasis. Now, dysphonia has been reported in up to 20% of patients receiving or using inhaled corticosteroids without a spacer device. I would just like to add that corticosteroids are associated with numerous adverse events. Now, while the low dose ICSs pose the lowest risk and the lowest exposure, especially via the systemic route, they still pose risks that aren't present with the SABA agents. Now remember, the ICSs are associated with osteoporosis, hyperglycemia, and even glaucoma. However, the risks of these adverse events aren't likely to be lowered with the use of a spacer device, since these are effects from systemic exposure of steroids, not oral exposure. I would like to remind you that inhaled corticosteroid agents are the preferred control agents for step 1 asthma, while a combination of ICSs plus formoterol is the preferred PRN agent in such patients. That's just a by the way. Let's move to the next question, please. And it reads, which of the inhaled corticosteroids listed below may be safer in a pregnant or an expectant female with stable asthma? Is it Beclomethasone, abbreviated or marketed as QVAR? Or is it Budesonide, marketed as Pulmicort? Or is it Fluticasone, marketed as Atrovent? Or is it Tiotropium, marketed as Spiriva? I'll give you 10 seconds to choose the correct answer. So budesonide it is, Pulmicort it is. Now, with the exception of budesonide, most inhaled corticosteroids are known to be pregnancy category C. Now, while the FDA has changed its reporting of drugs in pregnancy, budesonide has historically been known to be pregnancy risk category B, and it has been recommended by the ACOG as one of the preferred inhaled corticosteroids to use during pregnancy in the expectant ladies. Now, this is relevant since a patient with pre-existing asthma can experience a worsening of control, especially during pregnancy, that is likely to warrant the use of an ICS, an inhaled corticosteroid. I would like to emphasize that when at all possible, medications with safer pregnancy risk category should be used in management of such patients. So I would opt for budesonide and not beclomethasone, fluticasone, or tiotropium. Let's move to the next slide, please. And the next question reads, which of the anti-asthmatic agents listed below binds to the beta-2 receptor, activating adenyl cyclase, eventually resulting in a reduction in cytosolic calcium concentrations, thereby causing bronchial smooth muscle relaxation? Is it beclomethasone, marketed as QVAR? Or is it levosalbutamol, marketed as Zopenex? Or is it Ipratropium bromide, marketed as Atrovent? Or is it Ciclesonide, marketed as Alvesco? I'll give you 10 seconds to choose the correct answer. So levosalbutamol or Zopenex it is. Now, levosalbutamol is the only beta-2 agonist listed above, and it causes bronchodilation. Now, Ipratropium or Atrovent, on the other hand, is an anticholinergic agent that binds to the muscarinic receptor and not to beta-2 receptors, and that's the mechanism by which Ipratropium causes bronchodilation. And Dexamethasone and Ciclesonide are both inhaled corticosteroids, and they do not cause any form of bronchodilation at all. So all those many statements make answer B the correct one. Let's move to the next question, please. And it reads, HPB calls to a chest clinic about his 9-year-old daughter who is experiencing worsening asthma-related symptoms. He inquires if he could bring her back to the clinic for further evaluation and or treatment. So my question to you is, which of the reported findings listed below would warrant the need to seek further medical attention from your clinic by Mr. HPBO and his daughter? Is it wheezing that was initially heard out loud but is now absent, or is it a pulse rate of 88 beats per minute, or is it a PEF rate of 70% of her personal best, where PEF is a peak expiratory flow, or is it a respiratory rate of 18 breaths per minute? I'll give you 10 seconds to choose the correct answer. So A is the correct answer. Wheezing that was initially heard out loud but is now absent, and I'll tell you the reason why. Now, the only listed finding which is concerning, in my opinion, and possibly life-threatening, is the change in hearing wheezes to no longer hearing them out loud. Now, this would be suggestive of possibly mucus plugging and compromised airflow to the smaller airways, and this would especially be true if the patient was getting more lethargic or showing signs of exhaustion. So you need to be very careful when such symptoms ensue. Now, the other listed findings aren't as life-threatening compared to that case of the wheezing seizing. Now, I'd just like to emphasize that the GINA, the Global Initiative for Asthma guidelines, recommend that if the patient is experiencing or revealing the following, they should seek medical attention promptly or urgently. Now, that applies if the patient is breathless or hunched forward, and if the patient is only able to talk in words and not in full sentences, or if the patient is bradycardic or tachycardic, and that may apply to above 120 beats per minute for adults and adolescents, and above 160 for infants. And it can also apply if the PEF is less than 60% of the patient's personal best or the patient's predictive value. And it can also apply if the patient is exhausted or showing signs of further deterioration despite undergoing treatment, or if the patient's response to initial bronchodilator treatment isn't prompt or sustained for at least 3 hours, or if there is no improvement within 2 to 6 hours after starting oral steroid therapy. So watch out for those symptoms. If you see them, that points to the need to rush the patient to a chest clinic, to hospital or to an A&E for urgent attention. Let's move to the next slide, please. And the question reads, which of the statements below best describes the mechanism of action of ambrisentan, marketed as Letairis? Is it true that it is a prostacyclin vasodilator? Or is it an endothelin receptor antagonist? Or is it a phosphodiesterase 5 inhibitor? Or is it a stimulator of soluble guanylate cyclase? I'll give you 10 seconds to choose the correct answer. So B, in my opinion, is the correct answer. It is an endothelin receptor antagonist. I would like to remind you that ambrisentan or Letairis is an endothelin receptor antagonist used for the treatment of pulmonary arterial hypertension, abbreviated as PAH. Now, the receptor subtype ET-A causes vasoconstriction and cell proliferation, while this subtype ET-B causes vasodilation and anti-proliferation, and the subtype ET1 clearance also occurs under the influence of the latter. Now, in patients with pulmonary arterial hypertension, the ET1 levels are increased tenfold, and they correlate with an increased mean right arterial pressure, and disease severity. So pay attention to that when you look at the bigger picture or the clinical picture of such patients. Let's move to the next slide, please. And it reads, which of the statements below is correct with regard to chronic management of asthma? Is it true that Ipratropium bromide meter dose inhaler should be used twice daily? Or is it true that all patients should receive rescue inhaler of salbutamol? Or is it true that long-acting beta-2 agonist LABA should be started after starting inhaled corticosteroids, the ICSs? Or is it true that omalizumab should be started early on as a prevention of allergen-induced bronchospasms in the asthmatic population? I'll give you 10 seconds to choose the correct answer. So both answers B and C are correct. Now, I would like to emphasize that in addition to answer B, which reads that all patients should receive rescue inhalers of salbutamol, the first priority in the chronic management of asthma that has ongoing symptoms is the use of inhaled corticosteroids. Now, I would like to underscore that LABA should never be started before an inhaled corticosteroid. Now, Ipratropium bromide, which is marketed as Atrovent, on the other hand, is generally not used in the chronic management of asthma for most patients, and it's commonly used as a reliever medication in the treatment of chronic obstructive pulmonary disease, and it is dosed QID, not BD. I would like to add that omalizumab, marketed as Xolair, is a monoclonal antibody which is administered subcutaneously in the clinic setting, and it targets the IgE antibodies for the chronic management of asthma in patients who haven't adequately responded to inhaled corticosteroids and or LABA bronchodilator therapy. According to the GINA guidelines, this is started much later in treatment or in the treatment algorithm, not early on, and that disqualifies answer D and makes it wrong. Now, I'd like to add that all patients should receive short-acting beta agonist SABA as a reliever medication, followed by the inhalation of an inhaled corticosteroid. Then that should be maybe followed by a leukotriene modifier, then maybe a LABA bronchodilator therapy, with or without theophylline, then maybe you can introduce tiotropium. Then maybe the biologic agents when the earlier treatments prove insufficient in controlling the symptoms of asthma. I would like to also remind you that mepolizumab, which is marketed as New Color, is a monoclonal antibody that targets interleukin 5, and it's used in the treatment of asthma that is not controlled on inhaled corticosteroids. That's just a by the way for your information. And it's also administered subcutaneously. And there's also a drug, reslizumab, which is marketed as Sinqua, which is also a monoclonal antibody. It targets IL-5, and it's also used in the treatment of asthma that is not controlled on inhaled corticosteroids, but reslizumab is administered via IV infusion. That sets it apart from mepolizumab. That's just a by the way for your information. Let's move to the next slide, please. And the question reads, which of the medications listed below is used in the treatment of asthma only after patients have been adequately controlled on inhaled corticosteroids and is known to bind to IgE antibodies in the body? Is it theophylline, marketed as Unifilin? Is it omalizumab, marketed as Xolair? Is it azolestin, marketed as Astellin? Or is it tiotropium bromide, marketed as Spiriva? I'll give you 10 seconds to choose the correct answer. So omalizumab it is. Now the mechanism of action described above corresponds to that of an antibody or an antibody fragment that is known to inhibit the activity of another antibody. Therefore, in my opinion, omalizumab is the only option listed above that fits this kind of description. Alternative D, tiotropium bromide, is a LAMA, long-acting bronchodilator, muscarinic agent, so it doesn't fit that description. Let's move to the next question, please. And it reads, which of the options listed below would be the most appropriate following a chronic obstructive pulmonary disease exacerbation requiring oral corticosteroids? Would it be the administration of 5 milligrams of prednisone orally once daily for 5 days? Or would it be a dose of 40 milligrams of prednisone orally once daily for 5 days? Or would it be a dose of 40 milligrams orally once daily for 4 weeks? Or would it be 5 milligrams orally once daily for 2 weeks? I'll give you 10 seconds to choose the correct answer. So B, in my opinion, is the correct answer. 40 milligrams of prednisone taken orally once daily for 5 days. I would like to emphasize that systemic corticosteroids have been shown to reduce the rate of treatment failure and relapse during acute chronic obstructive pulmonary disease exacerbations. And prednisone 40 milligrams taken orally once daily for 5 days is the recommended course of treatment of acute COPD exacerbations. Now, the use of lower dose corticosteroids, that is, for example, prednisone 5 milligrams orally once daily for 5 or 14 days, would lower the risk of dose-dependent adverse events. However, such doses aren't appropriate for acute exacerbations of COPD. Now, longer courses, just like the option C, prednisone 40 milligrams once a day for 28 days, don't add benefit for patients with COPD exacerbation, but they increase risks of hypothalamic, pituitary, adrenal axis suppression, and they even increase risks of immunosuppression. So it complicates clinical outcomes in such patients by using such extremely prolonged durations of therapy. I'd like to underscore that appropriate dosing of short courses of corticosteroids reduces the risks of early relapse, treatment failure, and even they reduce hospital lengths of stay. So it's good to get it right from the word go. Let's move to the next slide, please. And the question reads, Mrs. KHR, 66-year-old woman, was recently diagnosed with chronic obstructive pulmonary disease. Her pre-bronchodilator FEV1 is 70% of the predicted value according to her spirometry results. She informs your chest physician that she becomes short of breath easily and often trails the rest. Yeah, she lags behind the pack when they are walking, and often needing to stop to catch her breath. Today, she has a CAT score of 12, and she experienced an exacerbation of COPD 90 days ago, 3 months ago, during which she was treated as an outpatient. She didn't require admission. According to the GOLD guidelines, which of the following is the most appropriate grade classification for Mrs. KHR? Does she belong to grade D, C, B, or A? I'll give you 10 seconds to choose the correct answer. So this lady falls in grade B. Now, according to the GOLD guidelines, patients with a CAT score of 10 or higher with 1 or less exacerbations not leading to hospital admission are categorized in Group B for treatment consideration. Now, Group A patients have a CAT score less than 10 with 1 or less exacerbations not leading to hospital admission. And Group C, on the other hand, encompasses patients that have a CAT score less than 10 but have 1 or more exacerbations leading to hospital admission. And in Group D, we have patients who have a CAT score of 10 or higher, and they have 1 or more exacerbations leading to hospital admission. I would just like to add that the GOLD guidelines revise the assessment approach for patients with chronic obstructive pulmonary disease. Now, I would like to emphasize that airflow limitation determined by the GOLD grade and clinical parameters, which are determined by the GOLD group, are now separated, which will help to facilitate a more accurate treatment recommendation based on patient-specific parameters and even the symptoms that they appear to have. Let's move to the next question, please. And it reads, JOJ, a 17-year-old Ugandan patient, will be initiated on mepolizumab soon at your hospital. Question to you is, which of the vaccinations listed below may be appropriate prior to the initiation of mepolizumab therapy in the case of JOJ? Would it be the polio vaccine? Would it be the varicella vaccine? Would it be the pneumococcal vaccine? Or would it be the influenza vaccine? I'll give you 10 seconds to choose the correct answer. So it would be the varicella vaccine. Now we know that mepolizumab, which is marketed as new color, is an interleukin-5 antagonist monoclonal antibody. Specifically, it's described as IgG1 kappa, and it is indicated for add-on maintenance treatment of patients with severe asthma aged between 12 years and above, not below 12. And such patients should have a eosinophilic phenotype of asthma. Now, mepolizumab is administered subcutaneously every 4 weeks, every 28 days. Now, herpes zoster infections have occurred in patients receiving mepolizumab nucala. Therefore, we should consider varicella vaccination if medically appropriate prior to initiating therapy with mepolizumab nucala. Let's move to the next slide, please. And the question reads, which of the agents listed below is a long-acting beta-2 agonist, LABA bronchodilator, which can be nebulized for the treatment of chronic obstructive pulmonary disease? Is it salbutamol, marketed as Ventolin? Is it formoterol, marketed as Foradil? Is it budesonide, marketed as Pulmicort? Or is it fluticasone, marketed as Flovent? I'll give you 10 seconds to choose the correct answer. So formoterol it is. Now the only LABA listed in that group of 4 is formoterol, and it can be used for the management of both asthma and chronic obstructive pulmonary disease. Salbutamol, on the other hand, is a SABA, short-acting beta agonist, which is available as a metered dose inhaler, a solution for nebulization, and even a syrup for oral administration. Now, budesonide and fluticasone are both inhaled corticosteroids, with budesonide being the only one that can be given by mouth, by both inhaler route and by nebulization. And I would like to remind you that proper recognition and use of short versus long-acting bronchodilators is important in the management of asthma and chronic obstructive pulmonary disease, where long-acting agents aren't used in acute exacerbations. Just remember that. Now, I would like to remind you that examples of long-acting bronchodilators, the LABAs, include formoterol, which is marketed as Brovana, formoterol, which is marketed as Perforomist, Inductrol, which is marketed as Arcapta, Olodaterol, which is marketed as Trivedi, Respimat, and Salmeterol. And the long-acting anticholinergic bronchodilators include aclidinium, glycopyrrolate, tiotropium, and umeclidinium or ameclidinium, depending on your school of thought. Just as a by the way, let's move to the next slide, please. And the question reads, Miss JWB, a 7-year-old white female, is brought to your chest clinic by the dad for evaluation for probable asthma following referral by the school nurse. Now the father reports that JWB has been experiencing 3 to 4 wheezing episodes at school every week, and he adds that his daughter has awakened thrice in the last 1 month with the same wheezing symptoms and occasional coughing overnight. Now, based on the information provided by JWB's dad, your chest physician diagnoses this patient with asthma. So my question to you is, how would you classify Miss JWB's asthma severity? Would you classify these as moderate persistent, mild persistent, mild intermittent, or severe persistent? I'll give you 10 seconds to choose the correct answer. So this is a clear case of mild persistent asthma. Now, based on the NHLBI guidelines, JWB falls into the classification of mild persistent. Now, reviewing the classification scheme for a patient between the ages of 5 to 11 years of age, this patient is experiencing daytime symptoms which are described by the dad as wheezing for over 2 days per week, but not daily. And remember, the dad also reports 3 to 4 nighttime symptoms. So those two factors, those two symptoms, qualify her to fall in the category of mild persistent asthma. Let's move to the next question, please. And it reads, Mr. D.A.M., an 18-year-old Hispanic male, was diagnosed with asthma several weeks ago. And as the clinical pharmacist at the chest clinic, you have been tasked to develop a pharmacologic regimen for Mr. D.A.M. So my question to you is, which of the medications listed below would you consider a quick relief or a rescue inhaler which should be included in Mr. D.A.M.'s regimen? Would it be mometasone, salmeterol, salbutamol, or theophylline? I'll give you 10 seconds to choose the correct answer. So salbutamol it is. Now there are two medication classes which are considered for quick relief. That is the short-acting beta agonists such as salbutamol, levosalbutamol, and the short-acting antimuscarinic agents, the SAMAs, such as Ipratropium or Atrovent. I would like to emphasize that the long-acting beta agonists do have some data supporting their use as rescue inhalers. However, due to the safety concerns, remember they have boxed warnings. If you read the literature inserts, they aren't recommended as rescue inhalers. Now, theophylline, on the other hand, is a methyl xanthine, and mometasone is an inhaled corticosteroid. And they are both used as controller inhalers and not rescue inhalers. So my highly esteemed viewers and listeners, that brings us to the end of this video. If this video benefited you in any way, please remember to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come. And I thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership and your continued and kind collaboration. I look forward to interacting with you in part 62 of our MCQ series. Thank you very much.